The second case is a patient where he's got right knee pain and he is having mechanical symptoms. And we're going to pause this and we're actually going to skip over now to, you'll get to see a brief intake and physical exam. Okay, so also for the students, refresh them on what's been going on with the knee.
This knee has carried the load for 15 years. When I injured this knee, I discovered I had a torn medial meniscus in 2009. At that time, this knee was so bad, the doctors like we could scope it and fix it or meniscectomize it, and I was like, we're just going to leave it alone. So I've been leaving it alone for a while as I've gotten more active and putting on weight via weightlifting. It's gotten to a point where it's mechanically causing issues and pain, and so.
And explain to them what you feel when you say mechanical issues.
So most times when this guy, like if there's mechanical, it's like a locking, right? So it's mostly an extension or flexion where you like really feel it. For me, it's more in the lateral movement. So doctor believes it's a flap tear. So it kind of goes like this over. So when I shift in like that wards, my knee will kind of go like that and clunk and click. Or if I'm on my back or on my side sleeping and I go down like that, I can feel it go clunk, 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 clunk. It's kind of.
So we know there's going to be some form of instability in the knee joint. And then where do you get pain? Medial side.
Yeah. Worse right there.
Okay. So already, based on where he's pointing, along with medial instability or medial pain, we suspect that the MCL enthesis on the femur is going to be involved. So, any clicking?
Yeah.
Okay. Did it ever catch?
Yeah, catch.
Okay. So those are again our common symptoms for an actual meniscus injury: is the popping, the clicking, the catching, and the locking. So
it'll get stuck, and then in order to move it, I have to go like that and up. There it is.
Yeah.
That's a small one. Usually it's way bigger, and it's uncomfortable, and it's a pressure I feel it in there.
Until it releases.
And it's big, and then I'm sore, and that's when the big ones are when my lateral side I'll feel it too, like sore. So no clicking, nothing mechanical over there. So.
Okay. Beautiful. Come on up for a second. Let me just move this up from the wall, and then lay on your back. Just relaxed. Any pain here?
Oh, a little pressure on the medial, but nothing.
Okay.
Painful.
How about in here?
Pain, felt like little clicks, bubbles.
Okay.
Medial side.
Medial side. Flexion and extension are within normal limits. Extension is non-painful. Flexion causes pain on the medial side. Is that your pain?
No, just pressure.
Just pressure?
Yeah.
Okay. And there's also popping.
You're feeling that too.
Yeah. Popping and instability with force flexion.
Yeah, there's
pain?
Yeah.
Where?
Medial.
Medial front or medial back?
Medial back.
Okay. So McMurray's positive for posterior.
That is miserable.
Okay. So nice and relaxed. For posterior medial horn. How are we on this side?
It's okay. A little weird sensation medially, but nothing laterally.
Okay. Remember, when you are testing MCL and LCL, you don't want to test it in an extended knee because you've got bony contact, and so it's very stable there. You have to unlock the knee in order to test. How are you here?
A little weird, like pulling pain, not bad.
Here or down lower?
Down lower.
Down lower, more here?
Higher than that, but yeah.
So over the joint line?
Yeah.
Okay. Familiar pain or no?
No, it was not normal.
Okay. Anything here?
Not really.
Okay. LCL testing is negative, but MCL testing is positive. Patellar apprehension is going to be negative. Contract your quad. Any pain?
No.
Clark's is negative. Any pain here?
I don't like my kneecap being pressed down, but not pain.
He does like that. Patellar grind test is negative. Let's test.
Walkman.
Anything here?
Yeah, that's uncomfortable when you pull anteriorly.
Anteriorly? And where do you feel the discomfort?
Can't tell you.
Okay. But ACL and PCL is negative because it's stable. Okay. And tenderness up here?
None. All good.
All good, okay. Up in here?
Nothing.
Okay. Come to the joint line. You okay?
Yeah, nothing.
Okay.
Tender.
Tender. All through here too?
That's worst. Oh yeah, that's worst.
Worse back here.
Yeah.
Okay, so medial joint line is tender, and it worsens as we go to the posterior horn of the medial meniscus. And then our coronary ligaments are also going to be tender.
That's all super
Sorry,
tender.
repeat that. Coronary ligaments, tender palpation on the medial aspect.
All very tender.
Okay. How are you down through here?
Fine. Nada.
Distal MCL and PES answering non-tender. Anything on here?
Nada.
Okay, so tibial tuberosity is good. Let's check. Anything in through here?
No. This feels good. Little massage.
Little massage. Okay. So over here I'm checking for popliteus because that little fluid that we found seems to be fine on palpation.
A needle will change that.
What's that? Needle will change that?
Yeah.
How you down here?
Fine.
Okay. How's this?
Fine.
How's this?
Sensation immediately, but like it's not painful. It's just weird.
Okay. So I think it's still gonna be meniscus. Recheck.
It actually felt nice when you were doing that. It's not nice.
You do have, it's not a ton, it's a touch
Lax.
more lax
Yeah.
on the,
Drawer test.
yeah.
Yeah.
Okay, so maybe we'll also treat your ACL as well. Okay, let's have you flip onto your stomach for a second. Let's just. Nice and relaxed for me. Any tenderness in through here?
I mean, I don't think anything significant, no.
Okay.
Felt fine.
Okay. How you down through here?
Fine.
Okay, so I think popliteus is probably fine then. Okay, so. Okay, so based on one, your imaging, two, the history, and your physical exam, I think the things we are going to treat today, we're going to treat intra-articular. That's going to help bathe the meniscus from the top side. Because we have the imaging and we know where your meniscus tear is, we'll actually do an intrameniscal injection coming from the posterior medial approach into the posterior horn. Inject a little bit of PRP into the meniscus. And then we'll come out of the meniscus, inject a little bit of PRP around the meniscus as well to try and help healing kind of from both sides. the coronary ligaments, which are insert the meniscus onto the tibial plateau. Those are often involved in the pain that we have with meniscus tears. So we will treat that. And I think that's everything we had, right? Intra-articular, mainly the meniscus.
Any MCL?
I mean, I'll look at the MCL under ultrasound. You had a little bit of pain with MCL testing, but when we test the MCL, you also stress that medial meniscus, so it's hard to know. You don't have any distal or proximal pain on palpation of the MCL, but there still might be something over the medial joint line that is just, we can't tell the difference on physical exam, because when I push on that part, I'm also pushing on the meniscus that's torn. So I'll look at it under ultrasound, and if we need to, we'll treat that. But I think that's a good approach. How do you feel about that?
Feels good.
Okay, beautiful. We will go get everything all set up.
All
right, welcome back. So now that that's done, so these, as you heard, the structures we treated are going to be the meniscus inside the knee joint, the coronary ligaments and things like that. And overall, that procedure went really, really well. We did end up flushing the knee a little bit, so we put a bit of D5W or 5% dextrose into the knee, and then pulled some of it back out. And the goal with that was to try and clear out some of the inflammatory stuff that can be found in the knee. And then we did our injection of PRP into the knee, followed by our injections into the posterior horn of the meniscus on the medial side, the coronary ligaments, and then also we ended up treating the infrapatellar fat pad as well. So with that patient, we are hoping that we can help him to avoid surgery, but have the frank discussion with him that if we don't see big improvements within the next 4 to 6 weeks from this procedure, then he is likely going to go have the meniscus tear repaired at the end of the year, which is just the reality sometimes with these cases that, regenerative medicine is powerful and can help a lot of people, but sometimes surgery is still a really great tool that we can use for patients suffering in pain.